So today we'll be looking at blood and bone marrow. By the way, how was that exam yesterday?
It was okay, miss.
Get everything right?
Boy, miss, I hope so. I think I messed up one part, but otherwise I think I did it.
For the first part,
Yeah, the labeling of the diagram.
sarcolemma.
Yeah, I put endomysium on accident. I saw it and I was like,
I suspected that would happen.
For me, it was the opposite.
Well-
I put I wasn't sure if it was endomysium, but
So you put sarcolemma?
Yeah, I did.
Well, good job. You got it right.
Thank you, Jesus.
All right. Today, I promise won't be as long as the others. It's less than 50 slides. So hopefully we can take probably 45 minutes to just do everything. Today we're looking at blood and bone marrow. It's basically the same thing that we did somewhat before. We're just looking at cells. Yeah?
Sorry, I was gonna ask you, since we're on the topic of the quizzes, so we have the nervous tissue quiz next week. What should we focus on?
What should you know from that? See, it's the same stuff that we talk about in the tutorial. Remember, we talk about the axon, the neuron.
Oh, okay, the neurons. Okay.
2 types of cell in the nervous system. We said the neuron, the glial cells, and you have 4 types in the central nervous system and 2 types in the peripheral nervous system. I would say know the diagram of the neuron itself, the axon, the dendrites, whether it's pseudo unipolar, bipolar. Know the Nissl body. Know that the oligodendrocyte myelinate the central nervous system axon segment. Know that the Schwann cell myelinate 1 in the peripheral nervous system. So the structure of the neuron and the cells in the central nervous system as well as the peripheral nervous system. So know the ependymal cell and the apical projection, and know that it makes CSF, cerebrospinal fluid. And if I should be evil, I probably would ask you how much CSF it makes in 24 hours. And well, for the final exam, I might ask you a bit more. I'll have a revision for that session, so you shouldn't feel too anxious about that.
And you said for the diagram, we should know the structure of the neuron?
Yes, know the structure of the neuron, know how to label it. Just like how you have the equivalent to Nissl body, rough endoplasmic reticulum, the equivalent to axolemma, sarcolemma, just the small things, axoplasm, perineurium, epineurium, similar stuff to the skeletal or cardiac muscle fibers, just connective tissue.
Okay, thank you.
And for the final, I might just ask you about the dura, pia, arachnoid, the mater, are the layers of the brain. Those are also connective tissues, the layer of the brain and the spinal cord. Oh, and I probably haven't said it to you guys. I'm not so much of a big fan of putting out my lectures unedited. I don't believe that the university has a right to me and whatever I do in live or in reality. They actually don't. A lot of people upload their Zoom sessions immediately after. That's great for them. I'm just not that person, and I'll never be that person. I have to listen to what I've said because I like to be thorough. Whether it's thorough or obsessive, I really don't care what it is. I'm just not going to be that person who will just upload my lecture wherever unedited, because sometimes you've given the lectures and you're speaking, you say things that are not so much factual at time, and you probably don't even realize until you listen to the editing or the recording to realize that you've made a mistake. So yes, nobody is perfect, but I would prefer to feel comfortable with my lectures before I put them on any platform. It's not a problem putting it on ENGBLE. I've literally just done a lot of editing on most of the lectures. So in order to just find back the original of the last cut of each, I would have to go through my computer and figure out all of those, which I really just don't have time for because I'm busy doing a lot of different things at once. My apologies for not having the convenience of having it on ENGBLE, but as soon as I can, I'll try to rearrange everything and upload them. Alternatively, I'll just upload them on the YouTube platform. It's not uncommon or unusual. Most prestigious universities all over the world actually put their lectures online on YouTube. It might just have this thing where it's not a culture. It doesn't mean that it's wrong or it's bad. It might just not seem like the most convenient based on what you're used to know, but nothing is wrong with it. If you guys have no more questions, we will be looking at blood and bone marrow today. So as I said, it's blood and bone marrow. Bone marrow because most of the cells that you'll be looking at are made in the bone marrow. Like almost all of them are made in the bone marrow. They're not made in the bone marrow, they're made in the thymus. So it's like blood is a lot of cells, and it's also a connective tissue. So everything that you learned about connective tissue, it goes for the blood. It's just a different type of connective tissue, just like the bone is a different type of connective tissue. So it's a specialized type of connective tissue, the blood, and it consists of cells suspended in plasma. So the plasma is the water part of it that is basically allowing the cells to move around freely while the heart is pumping the blood through different arteries, arterioles, capillaries for these cells to actually circulate in different areas of your body. The total amount of blood that is circulated in your body, you have an idea as to what that is already: 5 to 6 liters, 4 to 5 liters in women. So men tend to have a little bit more of everything. If you look at the protein, muscle mass, muscle density, in terms of metabolic rate, even their red blood cell count, they tend to have a little bit more of everything. The fresh blood is red, and you also have a fluid component to it. As I said, the plasma is the translucent and the yellow part. So if you look at the diagram here, if you subject the blood to centrifuge, as some red top tubes and some purple top tubes, when you guys come to the lab, I could actually show you them. I should have a centrifuge machine, not yet, but it's not hard to obtain. So when you get the blood, so for example, you stick a person and you take some blood from them, you put it, for example, in a purple top tube, depending on the investigation that you want, or a red top or a blue top or different color for different investigation. For this, if you, for example, get it in a purple top tube, you put it in a centrifuge, like a machine that spins it, and what it will do, it will cause the cell to separate themselves. So you see the bottom part that is red, you can assume that it's just the red blood cells that are down here, and here the buffy coat, you expect different types of proteins to be here, and the plasma, which makes up 55% of what you centrifuge, should be the water composition. So it has mostly organic molecules, has some cells. You have platelets. You know why platelets? You probably find platelets at this area. You know what the difference between platelets and other cells are? Anybody?
Platelets are cell fragments.
Exactly, very good. They're fragments, cell fragments. Remember what cells we said that the platelets came from in the bone marrow? So there are some giant cells called megakaryocytes. The cellular element of the blood constitute 45% of the blood, the volume in adults, while the plasma contains 55%. It's almost half, like 45% of it is cell, 55% is basically the plasma. This is an image just looking at the adult bone marrow. It's saying that this is where hematopoiesis takes place. Hematopoiesis is basically the formation of cells. For example, you can have erythropoesis. Erythro means red, erythrocytes. So if you see erythrocytes, it means the red blood cells. You can have leukocytes. Leukocytes means the white blood cells. And you can have also the megakaryocytes. These are the large cells that we said give rise to the platelets. So this is just showing different areas in the bone marrow where the cells arise. So they tend to come from hematopoietic stem cells. When it's hematopoietic stem cells, this means that they're cells from the bone marrow with properties. So these cells have the ability to differentiate in either leukocytes or erythrocytes. And you'll eventually realize that there are two types of cells in the bloodstream. They're either leukocytes or erythrocytes. Erythrocytes we know already are the red blood cells. Leukocytes we know are the white ones. Leuko means white. In medicine, if you see anything leukoplate, leukoplakia, leukopenia, it just means white. So sometimes you have description for certain things, and leukoplakia, for example, is just white exudate. Leukocytes now give rise to, any leukocytes? You guys should know this by now. Any white blood cells in the body that you know of already? You've covered some of them.
Phagocyte.
Yes. Phagocytes. And the other name for the phagocytes are what? Can be neutrophil, can be macrophage or monocyte. Remember monocytes or macrophage?
Yeah, macrophage.
Okay, so the difference between macrophage and monocytes is that monocytes are in the circulating blood while the macrophage are in the tissue. So if you see monocytes in the blood, it just means macrophage. It's just that the name changes because it's in a different location. For example, we say coffer cells. Coffer cells are some macrophages in the liver. So the names usually change because of the location or the location of the cell. So this is just showing like the bony trabeculae and sinusoids in the bone marrow, where the cells are synthesized and where they leave, for example, through the venous sinusoid to go into the circulation, like here, venous sinusoid. So if you look here, you can see probably fat cells, the white cells, you can see some fat cells here. And remember that the bone marrow is also fatty. You have fat cells, and you should also have the cells, and you have the venous sinusoids. This is a trabeculae here, and this is how they exit the bone marrow after they're synthesized, or after erythropoesis or leukopoiesis, which means the synthesis of red blood cells, white blood cells. This is just showing all the cells that we mentioned a while ago: erythrocytes, leukocytes. Erythrocytes, we say, are red blood cells. In terms of the size, they have different sizes and they have different lifespan in the bloodstream. So for example, erythrocyte, you should know that it has no nucleus. It's anucleate. It literally don't have no nucleus in it. It's devoid of organelle. In the development stage, it actually has a nucleus, but then the nucleus is extruded. So once the nucleus just come out, it becomes this biconcave disc, and it literally just has protein structures in it to carry around the oxygen and the carbon dioxide, and you'll realize eventually. So the function is to transport hemoglobin. The hemoglobin molecule is in it that will transport the oxygen and the carbon dioxide. Its lifespan is 120 days, so it usually doesn't live in your body for more than 3 months. So everything, as we say, cells tend to be synthesized and they're degenerated or regenerated. Almost everything in your body has to keep changing. So if you don't think that you need to keep changing over time, then it doesn't make sense. People who are stuck in old habits, old ways, it's an unintelligent trait, I think, because everything is always changing around you. So you need to always keep changing to keep up with time. And this is biology, evolution, teaching you that everything needs to change. Platelets, on the other hand, we call them thrombocytes. They are 2 to 4 micrometer in diameter. The erythrocytes tend to be a little bit larger. Platelets are going to be obviously smaller because remember that they're not really cells, they're just fragments of the megakaryocyte. Their lifespan is 10 days. They are very short-lived, 10 days. So sometimes patients come to the hospital, they have thrombocytopenia, which means that the platelet is low. If the platelet is low, sometimes you can give them platelet transfusion, but you have to have a date on it to ensure that it's not an expired platelet, because if you look, their lifespan is like 5 days. Usually 5 to 7 days they tend to keep them, and then they have to discard them. You see, because the platelets have an ability to clot or form clots, they agglutinate. When you preserve them, you have to keep shaking them, so you have to preserve them on something that keeps agitating. So in terms of the leukocytes now, are the white blood cells. The white blood cells include your neutrophil, your eosinophil or eosinophil, basophil, monocytes, lymphocytes. So the leukocytes can be divided into 2 broad categories. They can be granulocytes or agranulocytes, meaning that they have granules or don't have no granules. So granulocytes include the neutrophil, eosinophil, basophil. The agranulocytes include your monocytes and lymphocytes. In terms of the sizes as well, you don't really have to know the sizes so much. Red blood cell, know the lifespan is 120 days. It's 3 months. So if you're a female, and you should at least have mental capture as to what anemia is. For example, if you have menorrhagia or heavy menstruation, sometimes you find that you tend to be anemic because the amount of blood that you lose per month is more than your body can replace every 3 months. So you might just need to take iron tablet to increase erythropoesis, or the synthesis of red blood cells. In terms of the white blood cells, it's important to pay attention to the nucleus. Remember that platelet now have the nucleus because it's not necessarily a cell, it's a fragment. The red blood cell, we already know it's a cell that does not have a nucleus, it's anucleate. But for the granulocytes and the agranulocytes, you'll find that their nucleus can be segmented, where they have 3 to 5 lobes. Most cells that you've looked at before don't really have these type of features or characteristics, where the nucleus is just segmented or have lobes on it. So for example, the neutrophil, remember we talk about the polymononuclear neutrophil. This is basically what we're talking about now. It's segmented with up to 3 to 5 lobes. Eosinophil can have 2 lobes, bilobe. Basophil can be bilobe as well. In terms of the phagocytes, we know the phagocytic ones, the neutrophils, phagocytic, eosinophil, phagocytic. In terms of the clinical correlation, I might not tell you much in this lecture about clinical correlation, but you can already know that neutrophils, when you have a bacterial infection, you tend to see a lot of neutrophil, and we use this as marker in patients. For example, if they have a bacterial infection and neutrophil is high, we call it neutrophilia. It's likely a bacterial infection, you start them on antibiotic. Eosinophil, you tend to have this elevated in parasitic infection or allergic type conditions. So if them have any form of parasite, you have a lot of worms out there that kids can have. When you check them blood values, they might have a lot of eosinophil. The monocytes, they are blood phagocytes. They also can become elevated. For example, if you have a bloodstream infection, a bacterial infection, the basophils can be elevated in certain type of cancers, as well as even allergic type condition. Remember, we talk about basophil and mast cell as well. So the mast cells are a type of basophil that the name changes based on the location. And the lymphocytes now, you tend to see a lot of lymphocytes when you, for example, have viral infection. In terms of the component of the blood, we already know that you have the plasma, the buffy coat, and also the erythrocytes, or the area where you basically have most of the red blood cells or the cells in general. When a person takes a blood test from you, they look at hematocrit, which is the percentage of whole blood. So it's a percentage of erythrocyte in the whole blood. So the hematocrit varies for male and female as well. And the hematocrit can be distorted. For example, you can have an increase in hematocrit or a decrease in hematocrit. For example, if you have cancer of the red blood cells or even cancer in the blood. So in terms of the erythrocytes, we already know that they're the red blood cells, and you also have the leukocytes, which can be granular or agranular, and you have the platelets, which are the thrombocytes. You already know that the plasma consists of proteins, so it's just to fine-tune what proteins are in it. You have fibrinogen, globulin, albumin, ground substance. The ground substance is called serum. Remember, we said that it's connective tissue, so you expect the protein, you expect the water, and you expect the cells, just different types of cells this time. You expect red blood cells and white blood cells, as well as fragment of cells called platelet. You also expect protein. Protein can be albumin, globulin, fibrinogen. Albumin is a protein that is very common in the blood. If this protein is low, remember we talk about joint effusion and arthritis, and we're saying that if the glycosaminoglycan is reduced, then because it has the water attracting property, you basically can have effusion in the joint or a lot of fluid in the joint. Well, it's similar where albumin, if the albumin is low, then you can have swelling of the body. If, for example, you're nutritionally deficient and your albumin is low, your entire body can become swollen because the albumin is supposed to be in the intravascular compartment that will create this oncotic pressure. So if this heavy molecule is not within the intravascular compartment, it basically causes the fluid to shift to the extravascular compartment. So the fluid basically goes over into the connective tissue, and that's how you end up become swollen, and you call it edema. Globulins, you expect like immunoglobulins. You have different types of immunoglobulins that are made by the same cells, IgE, IgG, IgA. You have different types. You don't need to know them. Just know that there are proteins, albumin, globulins, fibrinogen, if you want to know. That is a component of blood. So hematopoiesis, as I said, is the synthesis of red blood cell or synthesis of cells in the bone marrow. The bone marrow is highly vascular. There's a medullary cavities, and there are vessels. There are a lot of blood vessels with different components that responsible for supplying the bone marrow itself and to allow for the synthesis of cells. The blood is a type of connective tissue. Both come from mesoderm. How many things come from mesoderm so far? You can make that as a wild guess for any question I ask you, and you'll probably get it right. So here we have bone marrow. You have intraembryonic and extraembryonic hematopoiesis. This just means that at a certain point in your life when you were being conceived, we already know that the blood cells are mostly formed in the bone marrow. The difference though is that during early life, when you are about 2 weeks or about 2 weeks after birth or even before, you normally have the red blood cells or the blood cells that are being synthesized in the yolk sac. So in the early life, the cells are synthesized in the yolk sac here, and during the rest of the fetal life until about 2 weeks after birth, the liver and the spleen is what synthesize the red blood cell. The lymphocytes, on the other hand, are produced in lymphoid organs. So you have B cells and T cells. T cells can be synthesized in the bone marrow. T lymphocytes can be synthesized in the thymus, while the B lymphocytes are synthesized in the bone marrow. That's the only outlier. Otherwise, after birth, growing up, your bone marrow is basically what synthesizes most of your red blood cells and even most of your white blood cells. So in terms of investigation for screening, you can do a complete blood count. You can, for example, take a purple top tube. It has an anticoagulant in it. It makes sense because if the blood will clot. Naturally, once your blood is exposed to the air, it clots. So you put there's an anticoagulant in this, and you basically can just take some blood from a person's vein, put it in this, it won't clot, and then you can centrifuge it. You can see the complete blood count. So you get an estimate as to the total number of red blood cells in for example, a sample, and also the hematocrit. So that's how you can tell if a person's blood count is low, if they're anemic or their hematocrit is low or high. So in terms of studying the blood and the elements in the blood, they tend to use blood film or a smear. And the procedure for a blood film involves placing a drop of blood on a glass slide, similar to what you've done here, like when you were doing the gram stain. But you go and put a smear, you're going to make a smear. So you're going to spread it thinly, and you'll add a cover slip on it, and you can basically stain it to see what color the nuclei or the nucleus comes up as, or in this case, for example, the red blood cells, you can see this area, this central area of pallor, they call it, where you normally expect to see the nucleus. And this is as a result of the biconcave shape of the red blood cell itself. So this is just stating the different types of stain, the Jimsa and the Wright stain that are commonly used to look at the cells in the blood. So as you know, the formed elements of the blood, you expect different types of cells. You expect cell fragments, you expect protein, and you expect what? So you expect the erythrocytes, which are the red blood cells, which should be somewhere here, anywhere. You can see these red ones, erythrocyte. They are typically orange to pink, and the nuclei, you can basically see the leukocytes as well, white blood cells. So the monocytes, this is the nucleus of a monocyte. This is a neutrophil, or the immature version. Sometimes I call it band cell. And you see how the nucleus is just lobulated. This is what it means when you say 3 to 5 lobes. Eosinophil, bilobe, basophil, also bilobe. You can see it right here.
Miss, you said the nucleus is lobulating?
Yeah, lobulated. So like it has lobes on it.
Okay.
You can have 3 to 5. Like this look like 1, 2, 3. So this is just giving a little bit more information of the component, the blood and the blood component itself. Also making note of the heparin or anticoagulant EDTA that you might have in the tube to prevent it from clotting, and the 3 layers that typically appear. So the 3 layers, the plasma, which you expect the water, protein, nutrients, hormones, the buffet coat, you expect some white blood cells and the platelets, and also hematocrit, you expect the red blood cells. So in terms of the erythrocytes, they are anucleate, as you already know, with biconcave disc. They're highly flexible. Why? Remember that your capillaries are very small. Capillaries can be as small as less than 8 micrometer in diameter. So these erythrocytes will have to squeeze through the smallest capillaries to get to the smallest area of your body. So it makes sense that it's biconcave and it's flexible, so it can bend, it can fold on itself. It makes up 99% of the formed elements. Makes sense. And also the lifespan is about 120 days in circulation. So in terms of the structural component of it, initially, as I said, it has a nucleus. It's nucleated, and during the development, not necessarily your development, but at some point it is nucleated, but during the regeneration of, for example, an erythrocyte, you usually have a stage where you have the reticulocytes. It's a reticulocyte, and at that point is when the nucleus is extruded from it, and then it just circulates as a mature red blood cell in your circulation without the nucleus. So during the final stage of erythropoietic development in the bone marrow, red blood cell lose the nucleus and almost all organelles except the cytoskeleton, and then enter the circulation. So there are different types of proteins on the cell membrane. These, for example, include ankyrin, spectrin. Sometimes you can have mutation in these proteins on the red blood cells, and you end up with disorders of the red blood cells. For example, you have a thing called ellipsocytosis, where because this protein is not present, it looks elliptical, or spherocytosis, where the spectrin, the protein is just not there, so it becomes spherical. And in sickle cell disease, there's also the sickling, or easy deformability of the cell itself, and even the oxygen carrying capacity is diminished as a result. As much as the red blood cell doesn't have nucleus, it doesn't have the organelles naturally, because it doesn't have these things, it's not going to be able to produce any ATP, right? There's no mitochondria, you don't expect ATP, so you expect a different way of getting the energy, right? Probably glycolysis. So are different pathways for energy. The important thing about this is to know that there are different polypeptide chains that are within the red blood cells, and they are important for carrying the ion. Remember that the red blood cells are there to carry the CO2 and O2. CO2 and O2, that's the main function. It goes to all the capillaries in your body through the lungs, take the oxygen within these beta and alpha polypeptide chain. There are specific areas that they carry the ion composition or component of the red blood cell, and the ion component of it will bind to the O2. There are different proteins or amino acid on these polypeptide chains that the carbon dioxide will bind to. and that's how it will exchange the oxygen and the CO2. All right, so this is showing the hemoglobin molecule. The hemoglobin molecule is basically what will be in the red blood cell. You have a lot of hemoglobin molecules, a couple millions hemoglobin molecules in one red blood cell, and each hemoglobin molecule will have 4 oxygen carrying capacity. So you'll have the heme, this is the globin, this is the heme and the globin, right? So the heme, this is the heme here, and this is the globin chain. So you have the alpha and the beta, as I just mentioned, the alpha and the beta chain, and you have on it a heme. This is where the oxygen will bind to the heme carrying capacity on the globin chain. That's where the O2 will bind to. The carbon dioxide, on the other hand, don't really bind so much to the heme. It binds to different types of amino acid parts on the globin chain, because remember, the globin is basically a protein. Remember, the building block of protein, amino acids. So the carbon dioxide will just bind somewhere randomly, and that's how the carbon dioxide gets transported. In terms of the values, you don't need to know the values, but 14 to 18. If you take some blood and you're looking for the male red blood cell count, the male red blood cell count should be a little bit more than the female. And as I said, you can have inherited and hemoglobin abnormalities where there is problem with the hemoglobin carrying capacity, there is problem with the structural protein anchoring spectrin, and you end up with a lot of different disorders as a result. So this is a little bit more on the hemoglobin molecule itself. You have 2 alpha chain, 2 beta chain, 2 alpha chains, 2 beta chains. Each alpha and beta chains have the heme on it. So this is a globin chain, alpha globin chain, beta globin chain, and you have the heme component as well. And on each you have 1 heme. But remember that the hemoglobin molecule, you have a lot. You have a lot, like a couple millions of them in one red blood cell. So the oxygen carrying capacity is a lot. So even though 1 beta globulin chain or an alpha globulin chain only carry 1 oxygen or 1 oxygen molecule, you have a lot of them in 1 red blood cell to carry as much as you want. So this is basically where the ion, the heme, the oxygen will bind to. And this is just showing a little bit more of what we said a while ago about the structural protein. Remember, it's a cell, it has a cell membrane. So the lipid bilayer here, and you should expect protein, structural protein, even cytoskeletal protein. So you already know that structural protein can be affected. Structural protein affected on any cell will produce a different pathology. So for example, the ankyrin, as we said, hereditary spherocytosis, it means that this protein structure is not there. So as a result, the cell is not so much biconcave anymore. It's a bit smaller and it's more spherical. So this protein structure is basically there to create the shape as well of the red blood cell. And if it's not there, it creates a different shape. And this is also the same thing for hereditary ellipsocytosis, where the cell can conform, have a different conformity. And these are also other proteins, spectrin, that can also be affected. The thing is with the spherocytosis, because this protein is missing, the cell is susceptible to osmosis. So there's a thing called osmotic fragility, where, for example, if you centrifuge it, the cell just collapses on itself with the membrane, the structural component, so it becomes spherical. So in terms of the leukocytes, we already said that leukocytes are divided into granulocytes and agranulocytes. The granulocytes include your neutrophil. We said the neutrophil are multi-lobe. It has a nucleus with multiple lobes. It can be up 3 to 5 lobes. In this case, you're looking at 3. Granulocytes can be eosinophil or basophil. Basophil, eosinophil are usually bilobe nucleus. In terms of the staining, it's basically just showing whether the stain is basophilic or eosinophilic. Eosinophilic stain means say it's pink, pink. So if it says bilobe nucleus, red cytoplasmic granule, the cytoplasmic granules are within the cytoplasm, which basically makes it look red. And blue cytoplasmic granule for the neutrophil. There are some blue granules as well that makes the cytoplasm look like this. And in terms of the basophil, bilobe. So it's easy to remember basophil, B, bilobe. And the nucleus is usually purplish black. This means basophilic. So if somebody says something stained basophilic, it means that it's stained bluish black. For example, the nucleus of this lymphocyte states basophilic. Even the cytoplasm look a little bit bluish, right? The nucleus here. In terms of the agranulocytes, the lymphocytes have no granule, and the monocytes as well. But the monocytes have a big kidney-shaped looking nucleus. And remember that the monocytes are the macrophage. The macrophage are in the peripheral circulation, the connective tissues. When you see them in the connective tissues, they are macrophage. So the neutrophils are the most numerous white blood cell in the peripheral circulation. And we already mentioned the polymorphonuclear neutrophil, where the nucleus has this distinctive morphology, and that's why they give it the name polymorphonuclear neutrophil. The nucleus can look like clumps, and you can have 3 to 5 lobes, and this is basically just showing that. So females often have a small drumstick-shaped lobe. They call it the bar body. It is absent in males and may be useful in determining chromosomal sex. This is just basically showing that small drumstick lobe that is supposed to be bar body. And in terms of the cytoplasm, it's eosinophilic, meaning that it's pinkish, right? Remember we said eosinophilic, if they're using that as a description, it means that it's about this pink color. If they say basophilic, it's purplish blue. They have small membrane-bound granules, and yeah, these granules have a lot of different enzymes that have different functions. So the neutrophils have azurophil granules, specific, primary and secondary granules. Basically, occasionally, large azurophil granules that stay reddish purple are the primary lysosome. They have primary lysosome, secondary lysosome. These azurophil granule or azurophilic granule contains myeloperoxidase. They have a lot of enzymes, elastates, proteinase, and defensin. And all of these are important for example, even with phagocytosis, they're important for digestion, cleavage, and even destruction of bacterial components. They have a small Golgi complex, a few scattered mitochondria, and some glycogen deposit, and they are motile. So this is just showing the azurophil, the primary granule, secondary granule, tertiary granule, what's in each. So what enzymes you can find: elastates, catepsin, lysosome, alkaline phosphatase, collagenase, B12 binding protein, different enzyme in different granules. So as we said, the neutrophils stay in the bloodstream for a very short time, 8 to 12 hours. Then they can migrate into venules and capillaries. They can become phagocytic scavenger in the tissues, and they are important for bacterial infection. So they're increased. For example, if you have an acute bacterial infection, you can just take some blood, you see the neutrophil, that's neutrophilia. It suggests that the patient is having a bacterial infection. The eosinophils are leukocytes. We said that they were granular leukocyte. They make up 1 to 4% of your blood. So the neutrophil makes up majority of the blood component. Eosinophil 1 to 4% of the blood. And somehow they have a diurnal pattern where sometimes in the morning they might be elevated, and in the evening it might just vary. And it makes sense because the eosinophil respond to allergies, pollen, whatever in the environment. So the nucleus, as we said, just like the basophil, can be bilobe, and they also have specific specific granule that contains enzymes such as histamine as well, just like the basophil and the mast cell. So this is just showing the eosinophil, the granules, primary and secondary granules, the protein that are contained within both the neutrophil, primary azurophilic granule as well. So the eosinophils circulate in the bloodstream for only 6 to 8 hours. The lifespan is 10 days, and you find them in the mucosal connective tissue, in the respiratory tract, the gastrointestinal tract, where you have contact with the external environment. So they release certain substance, enzymes, peroxidase, and even protein, and the cells phagocytose antigen antibody complexes as well as parasites. So you have an elevated number in parasitic infection. Basophils make up 1% of the total white blood cell count, and remember that these are bilobe nucleus as well. With bilobe nucleus, they contain histamine and heparin, and remember we said that the histamine and the heparin can be released and cause vasodilation. The basophils, similar to the eosinophil, can be increased, for example, in patients with allergic type conditions, chronic sinusitis, even leukemia, certain type of blood cancers. The basophils can be increased, but just like the eosinophil, they can also be increased when you have allergic type conditions. The lymphocytes account for 20 to 40% of the leukocytes. So we said the neutrophil account for up to 70%, the eosinophil up to 1 to 4%, the basophil 1%, lymphocytes 20%. We kind of put them in different categories based on whether they're granular or agranular. So the neutrophil, which is granular, is up to 70% of the cells, of the white blood cells in the blood. The eosinophil is second to that, while the basophil is 1%. So 70%, 4%, 1%. The lymphocytes, now we put this in a different category because it's an agranulocyte, and the agranular leukocyte doesn't have granule, but this makes up 20 to 40% of the blood. And remember that the lymphocytes are specific for viral infection. So if you take some blood from a patient and you see the lymphocytes are elevated, for example, if you have COVID, you expect that the lymphocytes sometimes, or all the time, to be elevated. And all lymphocytes derive from the bone marrow stem cell. Those differentiate and mature in the thymus are the T cells. So that was the only outlier that I was mentioning. Those that mature and differentiate in the thymus, they're T cells. Those that differentiate and mature in the bone marrow are B cells. That's easy to remember. T, thymus, B, bone marrow. Lymphocytes are the only ones that are categorized into B and T cell based on where they are synthesized. In terms of in the normal peripheral blood, 60 to 80% of the lymphocytes are T cells. So majority of them are T cells, while 10 to 15% of them are B cells. And you have markers on them that can differentiate which is which. So the T cell, remember we said that the T lymphocytes are important for viral infection. If you know anything about HIV, you know that the HIV virus attacks specifically the CD4 T cells. So you have different subcategories of these T or subpopulation of T lymphocytes. These are just the antigenic markers on it. So like CD4 is like an antigenic marker for a specific type of T cell. CD8 is a tubal marker for a specific type of T cell. So remember that some of the cells are going to vary somewhat based on what their functions are. So they have different molecular markers. Everything that is different is going to be different if you look at it from the molecular level. So like the CD4 T cells, we said that HIV tend to affect these cells or attack these cells. So we expect that somebody with an HIV infection should have low CD4 count, which is why we tend to do the CD4 count traditionally to see how the patient is responding to the treatment. There is also the viral load that they keep doing now. So they look at the load of virus that is in the blood or the bloodstream. That is a bit more accurate marker. B cells express different types of surface markers, just like the T. So when the cells are activated by antigen, they differentiate into plasma cells. And I think I mentioned this before to you guys. B cells are plasma cells at some point, and these plasma cells are what going to synthesize and secrete the immunoglobulin. So remember that we said that another component of the blood as being a specialized connective tissue was that it has globin or globulin. These are the immunoglobulins that are produced by the plasma cells. So you have IgE, IgA, gamed. So IgE, IgA, IgM, IgG, depending on the severity or depending on the type of infection. If the infection is acute, you might have IgM in the blood circulating, or the plasma cells will produce immunoglobulin M if you just get the infection for the first time. Or you might have IgG, which is the memory type of immunoglobulins. For example, if you get the same infection and you're exposed to it again, you should have immunoglobulin G that will just remember that you've been exposed to it before and should just eliminate that pathogen without you even having symptoms. And that's the idea. Well, that's not the full idea of the COVID vaccine, but somewhat. You're expected to produce antibodies, or you're expected to produce some T helper cells that will be responsible to induce memory that you've been exposed to the pathogen before. So that's a branch of immunology that you would have to go into to understand a lot more as it relates to even vaccination. Immunity can be antibody mediated, so you can have memory where you have immunoglobulins being produced against a specific component of that pathogen. You call it epitope or antigen. Or it can be cell mediated, where the B cells can produce the antibody as well and basically produce memory. And of course, you expect a rough endoplasmic reticulum based on the first lectures that we've done. Once you see a lot of rough endoplasmic reticulum, you're going to see it with Golgi complex, because it's synthesizing proteins, it's synthesizing immunoglobulin. So you'll need the protein synthesis, and you'll need the packaging, and you will need the release as well. So in terms of the monocytes, they are agranular. Remember, we said that the monocytes and the lymphocytes are two agranular. They are immediate precursor to cells of monocyte macrophage system. They constitute 3 to 10% of the total leukocyte counts, with a diameter of 12 to 20 micrometer. So you realize all them here big, the rest of them were not this big. They're the largest leukocytes in the blood smear. They usually circulate in the bloodstream only 1 to 2 days and perform almost all function outside the circulation. That's when you meet the macrophage. So the monocytes are actually the macrophages that are within the tissue. They actively motile, cells enter connective tissue to become macrophages or phagocytes. Each cells have a nucleus that vary in form and may have an oval, kidney shape, or horseshoe shaped nucleus. So the nucleus can just be big, look like a kidney right here. So I would say know what is bilobe, know which is horse shape, know what is 3 to 5 lobes. There are not so many that you need to know anyways. What's also specific about the monocytes, you have cytoplasmic fragments, pseudopodia, that are typical of the cell itself, that helps with motility. So it has like external projection or pseudopodia that helps it move around. Remember that it's going to spend most of its life in the tissues, trying to walk from one connective tissue to the next, to help you to live for a very long time by fighting against random things that escape into your connective tissue. So they cross walls, venules, capillaries, and migrate through the surrounding connective tissue. And you have a large number when you have inflammation, when you have sepsis. For example, if a bacteria escape in your blood, you expect a lot of monocytes to be produced. In terms of the platelets, there's motile cytoplasmic fragment enveloped by a plasma membrane. So they at least have a plasma membrane, and you already know that they arise from megakaryocytes in the bone marrow. These are the smallest element in the peripheral blood. Of course, they're not cells, they're anucleate, right? With a diameter of 2 to 4 micrometer appears as plate-like structures without nuclei. So they normally range from about 150 to 400, and if it dropped below the 150, they tend to call it thrombocytopenia. Anytime you see penia, leukopenia, or thrombocytosis, leukocytosis, it just means that you have a decrease or an increase in whatever it is. So they have alpha granules that correspond with the eosinophil, and they contain clotting substance. So the platelets are very important in, for example, when you get a cut, when you have a breach in the blood vessels, you have platelets just come to the area immediately. You call it platelet aggregation, and then they release a lot of factors like von Willebrand factors. The von Willebrand factor is by the endothelial cells, but once the platelets aggregate, you have the von Willebrand factors that are produced, thrombospondin and platelet-derived factors, and you have different pathways that are activated in order for clotting to take place. And sometimes if you have, for example, a deficiency in certain clotting factors, you end up with a bleeding disorder, call them hemophilia, and you have different types of bleeding disorders. So the clinical point, and the only clinical point that you'll probably see, everything penia, leukopenia, but anemia, all of those, it will refer to a decrease in the amount of whatever it is. So leukopenia would be a decrease in the white blood cells. Thrombocytopenia is a depletion of the platelet. And yeah, there's nothing really much relevant that you would need to know here. So in terms of the bone marrow, you know that it's a specialized connective tissue, and it consists of stroma or loose reticular connective tissue. A lot of cells are synthesized here, and there are a lot of venous sinusoids or islands. There are islands in the bone marrow that that separate venous sinusoids, and these are where the cells leave to enter the blood. So it has a vital role in lifelong production of blood cells and platelet. Two types of bone marrow. You have the red and the yellow bone marrow. Red bone marrow actively hematopoietic, and it's not abundant. So the red part is where you have most of the synthesis taking place. So it's abundant in prenatal life and in young. Its red color is due to the erythrocytes and their precursor. Until age 20 to 25, progressive fatty replacement of the bone marrow leads to yellow bone marrow. So you saw we have a lot of fatty cells as well. So as soon as you get older, you start replacing a lot of the red marrow with the yellow marrow or adipocyte. Venous sinusoids of the bone marrow are thin wall vessels and diameter of 15 to 100 micrometer. They form an extensive communicating network and are derived from branches of nutrient arteries to the bone. A single layer of extremely attenuated endothelial cell linked by gap junction, tight junction lines them. You also have a surrounding basal lamina. It's either absent or discontinuous. And you have reticular cells as well as fibroblasts branching. You have reticular fibers as well. So it's just another connective tissue, the bone marrow. You have adhesion molecules on the reticular cells, and the newly formed blood cells migrate across sinusoids walls to enter the bloodstream and then large veins. So this is just showing more like the pluripotent stem cell. Remember I said that the pluripotent stem cell give rise to all the cells. Basically, this is just looking at the stem cell. The stem cell can be myeloid or lymphoid. The myeloid will give rise to the erythrocyte as well as the granulocyte, and the lymphoid will give rise to the lymphocytes. So remember, the lymphocytes are the B cells and T cells. We said the T from the thymus, B from the bone marrow. And remember, we said that during any stage of development, the blast is the immature version. So it comes from a lymphoid stem cell. The stem cell will have to differentiate into a precursor cell, which are a progenitor, which give rise to the precursor, which would be the blast version of it. And the the site would be the mature version of it, which you would find in the peripheral blood as well as the tissues. So you would expect different progenitor, like colony forming unit, erythrocytes. For erythrocytes, colony forming unit for the erythrocytes, colony forming unit for the megakaryocyte, and for the granulocytes. So the granulocytes, for example, if you look at the red blood cells, it comes from the myeloid stem cell to eventually the progenitor, which would be the CFUE, which is the erythrocyte, and give rise to a precursor called promonoblast. Remember, the blast is the immature, and eventually you have a normoblast. They become the polychromatic normoblast, orthochromic normoblast. Then you have the reticulocytes. Remember that we said that the nucleus is extruded from the reticulocytes, and then it becomes the erythrocyte, and then it circulates in the blood. So in terms of the synthesis of a red blood cell, this is what you're looking at all the way down. In terms of the synthesis, you should know the cells from the myeloid stem cells and the lymphoid stem cells. What cells do they give rise to? So at least if you look at for example, the platelets, where they derive from the megakaryoblast, megakaryocytes to platelet. For the polymorphonuclear neutrophil, the promyelocytes, the myelocyte, metamyelocyte gave rise to the band. Remember, I was showing you that image with the band, and I said that was a neutrophil. That's just an immature stage. That gives rise to the polymorphonuclear neutrophil. And you can go through the diagram to see the eosinophil, the basophil. It's basically the same. The bone marrow is the site of hematopoiesis after birth. Remember, we said that you have the liver and the spleen that plays a role, as well as the yolk sac when you were in utero. It starts from the pluripotent stem cell. This is basically just showing the same thing. The erythrocyte, the granulocyte, or erythropoesis, granulocytopiesis. So in terms of the erythropoesis, we already went through that a bit. The progenitor to the precursor to the mature version of the cell. Well, it's good to know that the lineage that it comes from. And this is just showing like the nuclear exclusion before it becomes reticulocyte. And if you see, for example, red blood cell that is nucleated in the peripheral blood, you know that's an immature cell that is not supposed to be there. And this is basically just showing again the leukopoiesis, just like the hematopoiesis, granulopoiesis. This is basically just the formation of like a neutrophil, the myeloblast, promyelocyte, myelocyte, metamyelocyte, to the band, to the segmented neutrophil, to the mature neutrophil. And they have different types of enzymes in the primary granule, secondary granule, tertiary granule with different function. And you can read that in your spare time, and that's the end. Any questions?
No questions from me.
Okay, that was not such a bad lecture, right? So I'll try to make the other two a bit easier as well, and hopefully not so much more to stress you out, so you can feel confident that you will have enjoyed this course and hopefully learn something from it at the end of the whole thing. All right, so I guess see you guys next week, Tuesday. You guys said you want nervous tissue, so I'll prepare your tutorial for that. And yeah, that's it.
Miss, question.
Yeah.
For the finals, I'm trying to remember if you said the short answers, will they be similar to the tutorial quizzes?
Yeah, exactly the same. I'm not going to give you anything that will shock you or take you out of the element from what you're used to. And it will be simple. I'll try to make it 50 questions.
Okay.
Probably will be 50 questions and 2 hours.
Okay.
All right, that's it. See you guys next week.
All right. Take care.
Bye.